Hey everybody, Scott Moss here. I'm going to explain Cor Triatrium. Um, I've always wondered how that's actually pronounced. It could be Cor Triatrium, Atriatum. Um, I guess it depends upon who you hear it from. I'd go to the peds cardiologist and say, "How the hell do you pronounce this?" I just always pronounced it that way. This is also a very rare congenital heart defect. It is usually found incidentally unless there is a significant obstruction. So I'll show you what this is, and then you could see where a severe obstruction would cause problems. So let's get to it. All right, so this is a still image of Cor Triatriatum, and you can see how we're looking at what appears to be, obviously a membrane going across the left atrium. This can occur in either atrium, so don't just focus on the left atrium for this. It can be in either one. It's usually running across this way, on kind of you can see where it's here. But it can run this way. It can also run, this way, depending upon where the vena cavas come in and everything like that, or where the veins come in. So it can run in lots of different directions. So don't expect a perfect membrane every time. It depends upon exactly where your patient has their membrane. So as you look at it, realize that the most important thing at this point is to turn the color flow on and see if you get a high velocity jet going through that small membrane that's going across the left atrium. Remember, it's probably something I don't emphasize enough, but I should more often, is we're looking at a three-dimensional object with two dimensions. Now, not everyone has the luxury of having a 3D machine, and I've never been a big fan of 3D because I think it was in its infancy when I was I've been out of the field for about 4 years due to a lot of repetitive motion injuries, which is another thing we should talk about at some point in time. But it's something that 3D was in its infancy. You needed a lot of firepower and a computer to really make it work well. And when it first came out, you would have to have a separate unit actually interpreting the images and putting them all together into a 3D image, and it could take 4 hours. It was, because the computer drives weren't as fast and weren't as big, so it could take a long time to reconstruct a 3D image. So I think if you know what you're looking for and looking at and do a real thorough exam, you can get away without 3D, but in some cases I think it's great, such as getting a size of an ASD. I mean, I've seen that work extremely well for the surgeon. So, do I like it? Yeah, if it works well, I love it, actually. If it doesn't work so well, I think it's kind of a waste of time. So, well, there's another opinion for you. Everybody's got them like belly buttons. All right, here's another image, and this time it's on the right side of the heart, so in the right atrium. And you can see the membrane going across here. And like I said, it doesn't always have to go in a straight, one direction kind of way. It can go in different directions. So pay attention. It can sometimes be deceiving. You may think you're looking at a coronary sinus or just the enlarged superior or inferior vena cava, when the truth is that there's a membrane running across it and it's causing this, obstruction. So in the way of obstruction, let me show you what I've seen in the years I've been doing it. I've seen obstructions that are just very tiny. Hold on a second, I'm trying to get the eraser to work. Maybe as tiny as that, and it's causing a big plume of really big, vast plume of multicolored, you know, whatever else you want to add here, reds and blues, and it's causing a lot of turbulence. So that obviously is a more significant problem. You're getting significant obstruction there, and you want to take care of that as possible. It's actually a pretty easy surgery. They just go in and remove the membrane. You can also have a bigger, bigger hole, which obviously won't cause any of this. It'll just cause some basic red flow just going across the atrium and into the mitral valve area. And it'll be low velocity, so you won't see anything major there. This doesn't always come accustomed with mitral regurg. It doesn't always have any other defect associated with it. Anytime you see one congenital defect, you always have to look for more. I mean, that's just good common practice, but I don't recall seeing or hearing of a lot of extra congenital defects associated with this one. Like I said, I've been doing this for 30 plus years, and I worked at some of the biggest city hospitals in Chicago, so I mean, name it, I've been there, and with dedicated neonatal nurseries and congenital heart defect departments, and I have seen probably less than 5 of these. So it is rare. So when you see one, I don't want you to be surprised. It's just something you have to recognize. So that's why I'm putting it in your head. All right, so here we have a drawing just showing the picture of the extra membrane. Really, that makes it look like it has, the left side has 2 atriums two ventricles. This is one of those where, they would go in, they would remove the membrane, and, hopefully everything works out from there. So you go in, you cut this membrane out, and now you've got left ventricle going from here. If this stays too long, one of the problems you can have is the sides that are before the membrane can become atrialized. So, and what that means is they won't have muscle tissue there. They'll have more of an atrium-like tissue, a fibrotic type tissue. And that makes the left ventricle smaller, so you can have some of the symptoms of heart failure and low cardiac output. This is rare. Usually it's picked up before then, but occasionally people go, their whole life with this defect and it never bothers them. So depending upon how obstructive it is, that'll determine whether or not you're actually going to have problems. All right, every once in a while I throw in something that is a little bit different, and this is an MRI image of a membrane going across the left atrium. So it's the MRIs are still kind of growing up, so to speak, in cardiac imaging. They are a little roughly imaged, but they are great for picking up significant cardiac or congenital defects, especially like total anomalous pulmonary venous return and things like that. They can spot where the atrial or where the veins are being inserted. So in this case, it's obvious that you can pick up the membrane right here and right here, and obviously it looks like there's a significant amount of space where the blood flow can go through. So this is not something that is as significant, and they may even just leave this alone depending upon what their worries are, if there's symptoms or anything like that. So I just wanted to show you some different kind of imaging for it. So here we have a side-by-side image where you can see the membrane running across the left atrium here, and then you can see the color flow, and as you can see, the color flow is mainly just red, and it's not very turbulent. So that's a sign that this is not a big membrane. This is a membrane with a significant hole in the middle of it. So it's letting blood flow pretty normally into the left atrium and then into the ventricle. So again, I don't know what the percentage of them removing these membranes are as compared to leaving them in. Obviously, you don't want to do any kind of open heart surgery on somebody who doesn't really need it. So I'm sure that if the flow going through there is adequate, why open someone up when you're taking a big risk by doing so? All right, last image. This one I just wanted to show you how the membrane can be straight across or it can be jagged like this one is. You can see that it's taking different forms here, and as the heart goes between systole and diastole, you'll see that membrane probably shift into different positions. So again, it's very important to scan up and down in a 4-chamber view for this defect. So you want to scan from the aorta all the way down to the bottom of the posterior wall of the atrium and the ventricle in the 4-chamber view, so that you can rule this out. Sometimes you'll see a small membrane near the very bottom, and that's usually not something to worry about. But if you do see something right in the middle, obviously that's something you want to bring to the attention of the peds cardiologist. All right, that's it, folks. Try to get another one out as soon as possible. Hope you enjoyed this one. This is Scott Moss signing off. Bye.